Hello, I'm Mary Rose Bacani and welcome to Catholic Focus. Today I've decided to take a look back at history and explore the purpose of medicine and healthcare and the role and identity of the medical doctor and how this history informs the heavily debated topic of euthanasia. In today's episode, you'll hear from Dr. Margaret Somerville, an acclaimed writer and speaker. She's been researching and speaking about euthanasia for 30 years. You'll also hear from medical students and seasoned professionals in the field. But as all journeys begin somewhere, this journey begins in Ottawa with Shannon Joseph.
Shannon is an engineer and development officer who has also worked with World Youth Alliance, a group that promotes the dignity of the human person in international policy and in culture. In fact, she was just returning to Ottawa from her time with them in New York when she heard about Bill C-384.
First of all, the bill was called the Death with Dignity Bill, which I thought was very ironic. But if you look at the content of the bill, it's presented in the media as a bill that would allow people who are suffering and in palliative care to end their lives. But in the actual text, anybody who is suffering, whether the illness they have is a threat to their life or not, can ask for euthanasia. And it also says in the bill that this person is not obliged to seek treatment for their condition before asking for euthanasia.
The euthanasia issue has been rearing its head in Canada for the past 20 years. The issue has already gone unsuccessfully before the Supreme Court of Canada. Bill C-384, introduced by Bloc Québécois Member of Parliament Francine Lalonde to the Parliament of Canada, is the latest attempt. But what is euthanasia, first of all? The Special Senate Committee on Euthanasia and Assisted Suicide describes it as a deliberate act undertaken by one individual with the intention of ending the life of another individual to relieve that person's suffering, where the act is the cause of death. Bill C-384, if it passes, would amend two subsections of the Criminal Code so that a medical practitioner can legally euthanize a patient or assist in a patient's suicide. According to Shannon Joseph, the passing of Bill C-384 would drastically alter the identity and very purpose of the field of medicine.
Once a doctor has this new power, well, any power can be manipulated by healthcare cost considerations, by a caregiver who's tired, by whatever else. And that means that a patient can never be fully confident that a doctor is going to give them the appropriate care that they need. And if they're afraid of that, then they're not going to seek medical care. And if that happens, then the whole purpose of medicine has failed.
So after finding out about Bill C-384, Shannon created the website forum Canadians for Care.
I had found some doctors who didn't feel like their views were being expressed by what was coming out in the media. And so we got together, wrote a letter that basically clarified the terms of the debate and then said, we believe in a different type of healthcare. And Canadians for Care is a site that my friend and I created to host this letter so that other people could see it, sign it, doctors, nurses, medical students, and just the average citizen who agreed with what was being said and wanted their voice to be heard.
There are a few sources that we talked about of your strong convictions. And one was the book by Nigel Cameron called The New Medicine, Life and Death After Hippocrates. Can you tell us how that influenced your way of thinking?
It's a great book about the history of medicine and the emergence of Hippocratic medicine, because we always hear about the Hippocratic Oath and nobody knows anything about it. And this practice of Hippocratic medicine emerged in a society, ancient Greece, ancient Rome, that accepted a lot of practices that are being debated today. So euthanasia was one, infanticide of disabled infants was another practice that was accepted then. And this group of doctors under Hippocrates came out with a new approach to medicine. They said, above all, medicine is a commitment to a certain set of moral or ethical principles. And before learning the skills, you have to accept this set of moral principles. And those moral principles led them to exclude certain practices which were part of the Hippocratic Oath. So they excluded euthanasia and they excluded abortion. And the goal of medicine became to provide the best care for a patient at whatever course in life they were at. And I think the important message of that book is that medicine can't just be some a set of tools that we practice and that we can decide whether some things are ethical or some things are not. We have to know beforehand what's ethical and what's not ethical in the practice of medicine and commit to respecting that ethic as we deliver healthcare.
In the book, The New Medicine, Life and Death After Hippocrates, author Nigel Cameron states that in 1948, the World Medical Foundation restructured the Hippocratic Oath. The oath initially recognized a pre-existing moral order that physicians did not invent but were accountable to. The revised version made the medical profession responsible for the content of medical ethics, a radical shift.
Now, what is there in the Hippocratic Oath that stands the test of time, that's still relevant today for any generation? What stays and what doesn't?
Even if we don't have the Hippocratic Oath anymore, we still have an institution of medicine that has to have an understanding of what a human person is and how you can treat a person and how you can't treat a person. And regardless of whether we take oaths to Hippocrates or whatever else, we have to have a set of ethics governing medicine so that people can have confidence that medicine has an understanding of the person and will not do certain things, even if it is within their power to do.
How does euthanasia affect doctors and medical students? Are euthanasia and assisted suicide compatible with the role physicians and future physicians see themselves as having? What do they think their responsibilities are to society and to the field of medicine? Let's hear from them.
I think in today's society, there's a current trend to overemphasizing the patient's autonomy and self-determination and saying that I have the right to do this and the physician should bow down to my requests and really treating the physician as a technician in some cases.
This is a special situation in which it shouldn't be so easy just to let them to decide what they want to do because it involves the physicians, the greater society.
What we say in medicine for a long time is primum non nocere, do not harm, do not kill, because we know beyond being a doctor, we're human beings, and it goes against ourselves to kill.
If euthanasia were to be legalized in Canada, I think the training that we receive in medical school would be really negatively altered because our teachers, our professors, and eventually fellow colleagues would have to be teaching us how to kill a patient, which in my mind is really contrary to everything that I had envisioned when I decided to go into medicine in the first place.
Laurence is one of 15 medical students from 5 universities in Ontario and Quebec who wrote a letter that was published in the National Post on November 18, 2009. In it they say, "The human being is marked by a desire to be loved in spite of illness and misery. This need for an affirmation of intrinsic worth, despite vulnerability and dependence, cannot be satisfied by suicide. We, future physicians, will be watchful never to intentionally kill those patients who will be entrusted to us. Rather, we will be witnesses to their beauty."
I had a patient that I followed for 5 weeks. She was suffering from a pulmonary cancer, a lung cancer that had metastasis in the bones. And a few days before she died, she told me the only reason I can go through this is because I know you and another medical resident who was with me, that you share with me this path, that you have on yourself a part of my suffering just by accompanying me in a human way. And it's the only thing that can keep me going.
Research shows that there are many other reasons why people ask for euthanasia. There can be the fear of isolation, fear of losing their health, fear of maybe being a burden on society or family. I think these are many of the underlying reasons why they ask for euthanasia. And euthanasia can be the easy way out. Instead of having to deal with these problems and actually maybe not just offer some medication, but other options such as therapeutic options, psychiatry, nursing care, other types of options that can address these fears.
The legalization of euthanasia, I think it involves a risk for each and every one of us to see the human being in a utilitarist way, to see ourselves only in the evaluation of the acts we can do, of the actions we can take, and not our intrinsic value.
Dr. Ferrier and Dr. Moret from Quebec's McGill University Health Centre are two of the authors of a document outlining arguments against euthanasia. This document was presented to the Quebec College of Physicians in response to their anticipated position on euthanasia.
We as physicians, we start feeling this momentum in the society where the proponents of euthanasia was pushing very hard the agenda, and we felt it was simply not right that physicians should express their views about euthanasia and above all us against euthanasia.
We thought that euthanasia was not acceptable in any circumstance. And we started looking for other doctors to sign it, and we got over 100 doctors, up to 130 or 140 doctors to sign that, and we sent it to the college in the fall.
There is people who propose euthanasia as a way of relieving suffering. In fact, it's not a way of relieving suffering, but just to get rid of the person who is suffering.
When patients usually ask me, and they certainly do, to shorten their life, that they would like to die, what they're usually saying is, I don't want to live like this, I don't want to live suffering, I don't want to live with pain. And if we address some of these issues, we can usually manage the suffering. One of the big problems is that people often don't take the time to speak to patients about death and dying, and the fact that their treatments aren't working the way they would like them to.
Palliative care people say, you know, we can control almost all pain with painkillers, and if somebody's dying and we really can't control their pain adequately, well, then we can sedate them. So I think in the general public and among physicians, there's sometimes a lack of information about end-of-life care.
Well, the first thing people have to do is communicate, both with the patients and the families, to get an understanding of what's happening. What's the perception of the patient and the family about what's going on?
Dr. Ferrier has been working with caregivers David and Michael to better understand her patients' needs.
I've been seeing Dr. Ferrier since 2001, beginning with my aunt, and basically it was to assess the cognitive problems that we were seeing with my aunt and then later with my mother, so the memory problems basically for both of them. I think what they really need is to have someone on the journey with them, so someone who's going to offer them love and lots of support, and who can put them in a framework of a healthy framework, a safe framework. So whether that means nutrition, exercise, stimulation, just safety.
David has been bringing his mother to Dr. Ferrier for the last 9 years for dementia. David's father died of the same condition, and when David found out his father hadn't been seeing Dr. Ferrier for care, he and his brother decided to take proactive measures with their mother's situation.
In this case with Dr. Ferrier, one of the things that our family is happy about and blessed with is that we have a fair and balanced conversation, and the expectations are not more than what they should be or less than what they should be.
There's a lot of good things that can still happen late in the disease. You know, it's a very enriching disease for the caregiver. You learn a lot about yourself, and there's a lot of connecting and bonding that goes on a different level. You end up speaking to each other in ways that, saying things that you would not have said earlier in your relationship with the person. So there's a lot of beautiful things that can actually happen.
Because we deal with patients who are terminally ill and have followed patients through this journey, we know that they often change their minds. So patients who at first might say that at a certain point when they may need when they can no longer walk, for instance, they would want their life ended. And when they come to the point that they could no longer walk, they say, oh, this isn't so bad. When I can no longer breathe on my own, I would want my life ended. And yet we know patients with ALS or Lou Gehrig's disease often at the end of life do need a tracheotomy to help them breathe. And even though they said, oh, when I get there I wouldn't want it, they do want it because they adapt to the changes and change their minds.
And we've seen that in countries where it is legal, that it becomes sort of trivialized, one option among others, and then maybe the patient asks for it, but that's not really what they want, but they feel like they're being a burden on their family or something, and so that's why they're asking for it. Or they're depressed, and that's why they're asking for it. Or many, many, many reasons that are not a true desire to die. And if it's an accepted way of dealing with problems in your society, then you just say yes instead of saying, well, let's see it. Why do you want this? Maybe we can treat your depression. Maybe we can, get your children more involved. Maybe we need to find some kind of supports for you.
Never in human existence did you achieve so many means of controlling the pain or relieving the pain. Why it is now that people are asking for euthanasia? There is something happening in society, and I think we should be careful, not just agree with this new perception of an autonomy that is an exaggeration of a true freedom.
The central issue of the euthanasia debate is figuring out what respect for each person and for human life demands that we do or don't do. And this issue needs good ethics to get the right answers. And so I sat down with Dr. Margaret Somerville, Director of the Center for Medicine, Ethics and Law at McGill University.
For me, one of the major problems, for instance, in the euthanasia debate, is doing what I call putting a medical cloak on euthanasia. That we're used to thinking of doctors as being ethical, and the vast majority of them are. We're used to thinking of them as being compassionate and kind and relieving pain and suffering, which we all want them to do. And so when we say, well, we're just going to add some little thing to the end of this, like if you really want to, you can give a lethal injection providing the person consents, it seems as though, and this is what the pro-euthanasia people argue, it's just another little step along the path. And in fact, they've dropped the word euthanasia. They've even dropped the word suicide. They speak of physician-assisted death because surveys told them that the general public found that more comfortable and more acceptable. What that does is that medical cloak and that compassionate language dulls our moral intuitions about what we're really doing. So when I use the word kill, I get people furious at me. You wouldn't believe it.
What is happening in our society where we think if we see somebody suffering intensely, what we need to do is end it ourselves? Like what's happening?
Well, the difference is that you kill the pain, you don't kill the patient with the pain. And there's an immense difference. In actual fact, one of the problems in this area is that we've got inadequate training of many, many doctors. For instance, a lot of general practitioners have not been trained in latest pain relief methods, and they're extremely sophisticated, and when they're used, in the vast majority of cases, you can kill the pain and you won't affect the lifespan of the person, and nobody's got any problem with that. Then there is a technique called palliative sedation, where with the person's consent, you give them sedatives so that they're permanently sedated so that they don't experience the pain. But that's not killing the patient. The patient still dies from whatever their underlying disease is, not from the treatment that you give them. And then people say, well, if you're going to use palliative sedation, why is that different? The person's going to end up dead. Well, that's true, but it's the wrong issue. The issue is not in euthanasia debate, is not do we end up dead? We all end up dead eventually, something that most of us don't think about most of the time. The issue is how we end up dead. And are some ways of ending up dead, like lethal injections, a really bad idea? And I think they are.
The case of the Netherlands. And here's an example of a society where they've had euthanasia for 30 years or so. And we've seen the consequences of it.
Old and disabled people are refusing to go into Dutch nursing homes or hospitals because they're terrified of being euthanized. And in fact, there's about at least 500 cases a year in the Netherlands where people who are either not competent or haven't given their consent are euthanized. When euthanasia started off, it was sort of legalized through a court case in 1974. And it started off that you had to be terminally ill, in unrelievable pain and suffering, you had to be a competent adult, you had to constantly request euthanasia over a period of time, and you had to give your fully free and informed consent to it. Now none of those conditions are being applied, not one of them. The recent Groningen protocol, Dutch parents who have a disabled baby can have the baby euthanized within the first month of its life. Children aged 12 to 16 can have euthanasia with the consent of their parents. Those over 16 can consent to euthanasia themselves. So there's all of your requirements gone.
What is happening to our concept of, I guess, death?
Well, I think that with our loss of religion, we've lost a mechanism that helped us to live comfortably with mystery. And I mean, life is a huge mystery. I call it the mystery of the great unknown. We don't understand the real essence of life itself. I mean, that's a great mystery. And so is death. And so what we do is that because things we don't understand that seem very important can make us highly anxious, and we have free-floating anxiety, we often focus that anxiety on a particular fear. In the case of euthanasia, we focus the anxiety on death. And then what we do to reduce that fear that causes, we try to take control over the fear. And that actually, taking control does reduce fear. And so even though we can't avoid death, with euthanasia we can think that we've got it under control, that we can choose the time, the place and the manner in which we will die. And the other thing that we do in modern society is to convert mysteries into problems. So instead of the mystery of death, we have the problem of death. And then we ask for a technological solution to the problem. Well, the technological solution is a lethal injection. So once you start analysing what we're doing with euthanasia from these wider perspectives, you can see that it's a lot more complex than simply saying a lethal injection is a good idea for a suffering person.
When presenting on euthanasia, Dr. Somerville sometimes ends with a great quote from the late C.S. Lewis, and it is this: "We all want progress, but if you're on the wrong road, progress means making an about turn and walking back to the right road. In that case, the man who turns back soonest is the most progressive." So where do you stand on the euthanasia debate? Let us know, or order a DVD copy of this episode by sending us an email, focus@saltandlighttv.org. Once again, for Catholic Focus, I am your host, Mary Rose Bacani. We will see you next time.